think our two guests, they are now available. Dr. Maricar Belicena, actually, she was so nice to accept our request because she's seeing patients right now, and she was able to take time off from her patient hours, and then she's with us right now. And then also we have our Director of Clinical Integration, Donna Gunkel, with us. So I'm going to ask first Donna and then Dr. Belicena to introduce themselves.
Hi, good afternoon, everyone. Again, I'm Donna Gunkel, and I'm the Director of Clinical Integration here at United Medical ACO.
Hi, good afternoon. This is Dr. Belicena. I'm a primary care physician, internal medicine here in Bear, Delaware.
Dr. Belicena, thank you so much for joining us, and also Donna, as usual. Now, we do want to discuss this topic of, and I'll tell you, maybe we want to make sure that we get the most time out of you, so I can save my comments to the later time. But with our Medicare population, urinary incontinence and the fall prevention are the two problems that we are always having issues with. And then many people don't really understand how important this is. And some patients, they are not comfortable bringing this up. And we wanted you to kind of help us with what patients should know, how they can bring this up. Again, this is for our main focus for today is more on the elderly population for Medicare. How can we actually address these issues, and then from the clinical standpoint, how you are actually dealing with these and so on. So if you can kind of maybe explain us what this is, we can start with the urinary leak.
Yeah, so there are many reasons why patients encounter this incontinence, whether they're leaking or whether it's just related to certain activities like coughing or exercise. So mainly when I deal with these issues, it's pretty much on their Medicare wellness exam. However, it also comes up when they are having symptoms like, they say that they're leaking, or when they're coughing, they have a little bit of leak. Or one of the things that I really ask them during a wellness exam is, do they wake up in the middle of the night to urinate? And because to me, that's a safety issue more than anything else. The reason for that is, of course, they're during the evening, just because they're sleepy, the area can be dark, it's not well lit, they can fall, trip, and basically break their hip. So that's really a safety concern more than anything else. And then when it comes to the different kinds of urinary incontinence, it really, to them, it's really not an issue. It's basically for the providers to say, okay, because of what you're telling me or what your symptoms are like, then this is the way to go. Whether it be a Kegel's exercise or whether it be medication, or whether it's just been training, like, okay, before going to bed, let's say, what time do you go to sleep? And they say, okay, maybe 11 o'clock, 10 o'clock. I'll say, okay, so if you sleep at 11, go ahead and maybe last drink should be at 8 o'clock. And then even though if you don't feel like urinating or peeing before going to bed, just go urinate. So then the hope is they won't wake up in the middle of the night to urinate. So that would be how I would address these kinds of situations. And with regards to, there's different kinds. There's stress, there's urgency, there's overflow, and those come with a certain type of diagnosis. And most common cause of incontinence is overactive bladder. And women most commonly will experience this, but of course men can do that. But of course, for men, it's most likely due to prostate issues. And that comes when they're elderly. The other thing with women is when they're too busy taking care of the kids, they hold their urine, or they're working too much, and before they know it, they forget, like to go to the bathroom. And sometimes that's what happens. And then they cause some incontinence with that. So it's just basically educating these our patients and say, okay, what's the situation? When do you have these problems? And to address those kinds of issues when they come up.
So, Dr. Belicena, do you feel like if the patients are having difficult time to bring these issues up, and then I have the same question in a different way, do you sometimes feel from not for you, maybe personally from the clinical side, do you feel like sometimes primary care physicians, maybe they're not bringing this up unless the patient says something?
Well, from my personal experience, it's not a problem for me because that's part of the review of systems. That's part of I ask, like, do you have issues with urinating? Is it painful? There's blood, there's pain. And do you urinate? How frequently do you urinate? So that's part of the review of systems. That's, part of the physical exam. And not only that, let's say they come in and they have issues. Let's say they have urinary tract infection. So you want to say, okay, when was the last time you've had an infection? What's the situation? What are your other symptoms? And so I guess with women, for me, it's not a problem. The other thing too, I would maybe on the EMR side, it would probably be helpful sometimes because sometimes I have to look around where the urinary symptoms are, and it's easy. Probably would be on the banner, so then it's right there, and it's a good reminder for us to say, okay, you need to ask these things, especially with the elderly. But that's part of my Medicare wellness when I ask patients.
So from the elderly standpoint, and I say elderly, but this is now 65 and over, the population we are talking about.
Mhm.
I really shouldn't say elderly for 65. So now the overflow, and this is the functional, right? The functional incontinence. So these are the two most common. And now this is the one with the disease related, such as diabetes, and this is just from the age. Now, from the treatment side, now what would be the best way to, like, what is your choice of treatment when this happens, either from the overflow or from the functional?
So because the overflow would most likely, never say never, but most common in men because of the prostate, because you're blocking the prostate, right? And so you want to make sure. So of course, a good history, very important, very, very important with good history, because a lot of times it's not clear cut with incontinence. And sometimes it's just, overactive bladder. And then for the neurogenic, of course, that could be it could be a spinal cord issue, not most commonly, because for diabetes, it could be many different things, because high sugar itself is a diuretic. So when their sugar's high, they'll be peeing a lot. So one of the things that we really ask with people who have diabetes is, do you wake up at night, and how many times do you wake up? It's nocturia, basically. So that's one of the things that we ask, symptoms that we ask when they follow up with us, because that's a red flag. Would say, oh, your sugars aren't controlled. Yeah.
I guess in some of the cases with the water intake, right? So the timing of that. Now the other problem is with as the age comes into the equation, disease like such an Alzheimer. So those patients do have actually one of my family members is going through that problem, and it's challenging because the problem is that they forget that they eat or they already drink, and then they start drinking again and they repeat the activity again and again. How is the treatment options, or what are your suggestions for that population?
A lot of times we give them a trial. There's many medications right now to see if that's going to help. But when we're dealing with Alzheimer's, the way that I think about it is like, when you're training your babies or your kids, when you're toilet training, you have to remind them, like, okay, it's time, make sure so they're not having accidents. So maybe every 2 hours, every 3 hours, put a timer in. So just it's a reminder, or if they if they have a cell phone, you could put a timer there. So it's just a reminder. So it's, to me, it's just like potty training when it comes to issues like Alzheimer's. The other thing is, there's Myrbetriq, which is really good. In the past, you could either use both. Some urologists use both Myrbetriq and Vesicare as a combination, and that seems to work out pretty well. And with regards to coverage and side effects, Myrbetriq really is, I think, superior.
One of the things that I see, and I was just talking to Sean earlier, when we do our case conferences, we do deal with patients who have complications and high complex chronic illnesses. And one of the big problems that we see is the issue of these patients not actually getting enough support at home. And they're not in assisted living, they're not in a nursing home situation, they're home. And unfortunately, part of our culture here is that we have we don't have the same support. Like I know, like you are from Philippines, I'm from Turkey, and the dealing with our elderly population is different. So we do have more family support than here. So I think one of the problems that we are kind of seeing again and again is if the patient is not bringing this up. I think I do want to spend a little bit of time on this patient experience issue. From the patient experience side, like we have, we do have we have this embarrassment. I don't know if it's just me. I have close to 400 providers I work with, and 160 of them, they are in the ACO, 180 maybe. And we still have this embarrassment when we have issues to bring up to our PCPs, our physicians. Now I'm going to be volunteering for this, and I have that problem. So if I have some problem, I'm going to do more Google search before I ask something to Dr. Belicena. So do you think that's part of the problem that patients
It could be, but the way that I present it, it's like, nonchalantly, it's like, oh, do you have headache? Do you have dizzy? Are you lightheaded? Do you have any chest pain, shortness of breath? Do you have problems urinating? Do you pee? Do you pee your pants? Do you, that's like the things that I do. So it's not like I'm intrusive, I'm being degrading to them. It's what I ask them, and it's part of what I do as a provider, as a physician. So it shouldn't be something that's like, oh, she's asking me because whatever. But so it comes out as a natural kind of question and answer situation, rather than more of a, oh, you're doing this or you're doing that. So when I see, I'm talking about me, but so it's not like something that's intrusive when I ask them about those, about urination or about incontinence.
So we were wondering, like, the way the question is phrased, if maybe depending on the way it's asked by the doctor and then the way it's asked in the survey, because that is one of the issues that Kamal is talking about, is our patient engagement. So after patients have like their Medicare wellness visit, they do get a phone call, a survey, like from Humana or from United Healthcare or from Medicare. So the way I'm kind of looking at our book here. The way the survey question reads is, did your doctor discuss bladder control or issues with urine leakage? And kind of across the board, it's low, not just with our patients, but in general, with, like across the board, it's much lower than a lot of the other questions, like, could you see your doctor when you wanted to? That's a much higher number. So we didn't know if you had any thoughts about that and maybe the way it's asked.
I think so. I really do. Because if they mention the word bladder, I don't think it crosses that threshold between what the patient understands as to
Right.
what the question is being asked.
Right.
Because you sometimes when I say those things, they're like, what? What's your question? So they don't even get what I'm asking. So I say, do you pee your pants?
Right.
Or do
And
you,
that's
you
what
know,
I'm wondering is
yes.
because of the way the
Yes,
question is phrased
yes,
about
for sure.
bladder control or issues with urine leakage, if they're not hearing that exactly the way
Mhm.
that is. So, that's one of the other things that we were looking at is there like a way, and also we're trying to send out some additional emails so patients do become more familiar with this and feel more comfortable about
Right.
talking to their provider about those
Or just
those
maybe
type
like
of things.
put a parenthesis below that, like examples, maybe, that's kind of things. Because if you say bladder leakage, I don't think they 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 would necessarily think about that in
Right.
terms of, oh, I'm wetting my pants when I go to the bathroom, or I'm leaking a little bit, or
And
that's
these are,
kind
I
of-
think, automated, like, because we don't do them. These are, put out by Medicare. But
right.
certainly we've had conversations with the insurance companies in our monthly meetings, and part of that is they ask us, how do we address this with our patients, and do we have any ideas? So that's a good point. Is you may be asking some of those questions about how often they go and different things like that, and they may not always be relating it to the way the question is worded in the actual survey.
Like, for example, do you wet your pants when you jump, when you do your exercises? So when I ask those questions to that patient, do they necessarily think that it's a bladder issue?
Right.
So they won't probably think about that, but that's what I mean when I ask those questions.
Right.
Yeah.
Or even the leakage part, or
yeah.
So I do think sometimes it is the semantics, how we say it or how they're saying it, and putting that together. So I think part of it too is just making sure that the patients hear those things, that they become comfortable if they're uncomfortable or, as Kamal said, embarrassed about having that discussion with their doctor, but that it is important because one thing can lead to the next. So I know one of the things you had mentioned a few minutes ago was if they get up in the middle of the night, your concern is them falling, and that's like our next topic. So it kind of leads into that where, we're concerned about fall prevention from a variety of perspectives for patients. So sometimes those things do go hand in hand, or they do, impact each other.
Well, actually, Donna, what you said is what I was about to just go into, because fall risk and the fall-related injuries is one of the most severe and the costly problem for the elderly population. Now, I was part of the trauma program for St. Francis Hospital in the beginning, so we had to do a lot of statistics, and 50+% of the trauma cases are coming from the fall cases, one-level fall cases. So 50%, a little more than 50%. Now, this, when Dr. Belicena mentioned this night, getting up at night, and how that's linked to the fall risk, it's kind of like extremely, important from our point that this number, the fall increase, actually did increase. That's about 30% in the last 10, 12 years. Now, as this is increasing, the cost is increasing. But I think the biggest problem even before the cost is healing from this process is a lot more difficult for the elderly. So if they break a bone, for them to heal, it's going to be almost so difficult, right? So now, what can we do for what are the facts about the fall in the older adults, and what can they do? If we can just go through that a little bit.
Sure. So, I did pull out a few statistics out there from the CDC. So each year, millions of older adults, again, we're talking 65 and older, fall, which is about 1 out of every 4 older adults fall. But as you can see here, less than half tell their doctor. So it is one of the things, and I'm sure Dr. Belicena will agree, it's part of that Medicare wellness visit. So one of the other things that's done during that visit is actually a screening about any potential, the potential for current falls or future falls, but also have they fallen recently, and then looking at those kinds of things. So again, what may lead to them falling? It can be, weakness. It can be medications that they're on that cause them to be, as Dr. Belicena said, dizzy or have vision problems, or, a number of other things. It could be the vision problem. It could be foot pain. It could be home hazards. So that's also important to remember, that they want to have, hopefully not clutter, get rid of any items like loose rugs that they could trip over, other things laying on the floor, utilizing bars like around the toilet or the shower, things of that nature where they may need assistance, in standing from a seated position. Sometimes also making sure when they sit in a chair that it has arms, perhaps, so that they can help push themselves up or have something to hold on for stability. So again, one of the things that we want them to do is to make sure they are talking to their provider about those kinds of things, so that an assessment can be done. And I'll let Dr. Belicena talk a little bit about that.
Yeah, so part of the physical, or whether they're probably having problems with their back, or having problems with their legs, or just any ambulatory issue. One of the things that I check is when they're lying down and they push on their feet towards me, so that I can feel how much strength they have, basically with their thigh muscles, because that's what they use to stand up, basically. And that's what I check. But one of the things that's really, I think, very revealing to me is I ask them to sit and I ask them to stand up. A lot of times they need to prop up themselves with their hands. And I said, what if you put your hands on your lap and then stand up for me? And most of the time, or like, I want to say between 70% of the elderly, and I'm talking about 75 and up, they have difficulty doing that. Mm-hmm. So then, I'll segue to that, but I usually refer them for physical therapy for fall risk and that sort of thing. But really, I try to explain, okay, you need to try to strengthen your core muscles. And that way you don't fall, and strengthen your thigh muscles. In women, when I ask them about this, it's funny because I say, when you go to the bathroom, in public, do you sit on the commode or do you squat? So that's a revealing, answer, because when they squat, I notice that they're stronger, like they don't fall easily. Mm-hmm. It's because, they're able to do that. But with men, they don't necessarily do that when they pee. So I find that when they try to balance on one leg, it's a problem. They have difficulty doing that.
I think the main issue, one of the things that we really need to kind of remind ourselves is that I think preparing for those days, those years, now the population, the life expectancy is much higher than where it was 20 years ago, 40 years ago. Now, I think the projection of some of those people, they're like, well, I'm going to die before that age, so I don't have to really prep much. So it's not those anymore, right? So like even today, like when you hear someone who dies at age 75, you feel like that's too young, right? I mean, how many times do we feel that way? And it is. So then I think we need to really prep our population better for these days. So exercise, daily exercise is extremely important, and then they just need to walk, keep them active, keep themselves active, and even with the small weightlifting activities at home, they can easily do that. Now, Dr. Belicena, I know you are actually seeing patients, and then we are okay if you need to take off.
Thank you.
Well, thank you so much for joining
Thank
us.
you.
It's
Thank
extremely
you.
important to have you. Thank you.
Bye.
Thank you.
Thank you. Bye.